Hi, I'm Brian Miller, your Associate Medical Director. Today, I'm excited to present to you the Crashing Pediatric Patient Protocol series. Pediatric patients comprise about 8 to 10% of our overall EMS volume, yet crashing pediatric patients are much more infrequent. However, the public expects the same level of service for a pediatric patient as an adult. Yet, when you think about our CE cycles for both the system and National Registry certification, pediatrics are a much smaller focus than adults. And so what I ask for you to do today is to take a dedicated focus on these lectures, as well as afterwards continue to study your pediatric protocols to continue to improve the care of our system. So what are we going to do today? First, I'm going to go over an overview of pediatric patient assessment, as well as some pearls and pitfalls for pediatric patients. Next, we're going to move into the PEDS crashing patient protocol for medical patients. And then finally, we're going to wrap up with the crashing patient protocol for pediatric trauma patients, as well as the traumatic cardiac arrest protocol. So let's address right off the bat the elephant in the room. Quite frankly, it's a herd of elephants in the room. Crashing pediatric patients are rare. They scare us. We definitely have less training in them. They're very stressful. We feel that the pediatric patients are different than adults. And also, we do have less opportunity to practice or care for pediatric patients as they're adults, and therefore we lack the experience compared to our adult population. What I want you to do through these lectures is to reframe your mindset. I want you to think about pediatrics as not being so different from adults, and that you have 95% of the things that you do for adult patients that you can apply to pediatrics as well. There's some small things that we can think about that are a little different for pediatrics, but overall, the care of them is very similar to your adults. So for EMS, kids are really small adults. You don't need to be a pediatrician. You don't need to be a neonatologist. You don't need to be a pediatric emergency physician to care for pediatrics. They're just not that different overall, and we don't need to get into the minutia and the small details for our level of care. Also, pediatric patients are much easier than our adult patients. Our adults are usually balancing multiple comorbidities all at the same time. They have their COPD, their CHF, and their dialysis all going wrong all at the same time. It's much harder to care for a patient like that. Pediatric patients are often one-hit wonders. It's one system down, and we can use some BLS or some ALS skills to treat that patient and rapidly turn them around oftentimes. So overall, I want you to take away that you have the tools, the skills, and the knowledge to provide excellent pediatric care to the citizens in our system. So here's the adult crashing patient protocol. We have already gone over that in our previous crashing patient protocol series. If you haven't watched that, I ask you to go back and review that first, as the principles for the adult crashing patient protocols are very similar to the pediatric protocols as well. So here's the pediatric protocols. As you see, it's very similar to the adults. That was very intentional. We wanted you to feel that it was similar to the adults with the same flow as well as the same steps, except for a few differences for the pediatric populations, mostly for the age-appropriate vital signs, as we see both in infants all the way up into that 14-year range. So here's the goals for our pediatric patients. For medical, the respiratory goal remains an SpO2 greater than 94% or persistent hypoxia despite advanced maneuvers. Next, for our circulatory goal, you see it's changed a little bit in its resolution of hypertension or shock to address the age-appropriate part of our vital signs, or the initiation of vasopressors after contact with OLPG. For our trauma population, it's very similar as well. Our hemorrhage goals are still control of hemorrhage or maximal therapy per our protocol. Our respiratory remains the same as our medical. And then finally, for our circulation, it's again trying to establish back our age-appropriate vital signs or hyperperfusion despite our maximal therapy. Here's the patient assessment page in the new protocols. You see we've added a few different things. First, there's a definition of pediatric patient. Next, we added some language about referencing pediatric dosing guides. And finally, we added the crashing pediatric patient language, and they're similar to the adults. The definition of a pediatric patient is 14 years or younger, and they either fit on a length-based resuscitation tape, such as a Broslow tape or a Pedia tape, or they're less than 36 kilograms or about 80 pounds. Just remember, though, that just because they are treated on the pediatric protocols, you still need to reference the destination guide as far as where you're taking your trauma and your psychiatric patients, as those may be different than the definition of a pediatric patient. So let's talk about the pediatric assessment triangle a bit. At first, I thought this was kind of hokey, but in reality, this is our primary assessment for pediatric patients. If you're kind of confused where to go when you see a sick pediatric patient, this should be your first go-to. Stop, step back, and observe the patient when you walk in. They often tell you a lot that you need to know just from the door exam alone. The pediatric triangle gives you a visual assessment. Sick or not sick when I walk in. Also, by these simple things, I can often determine what is the physiological abnormality for that patient just from seeing them from across the room. So the pediatric triangle consists of 3 different things: appearance, work of breathing, and circulation. And so let's go into those components individually. Let's get into appearance now. First, our mnemonic is tickles, T-I-C-L-S. That relates to tone. So how's that patient looking? Are they running around the room, having great tone, moving everything? Or is it a floppy infant just laying there with not supporting their head and just kind of laying in the parent's arms? Also, think about interactiveness. How is that child interacting with both you and their caregiver? Are they looking around the room and examining everything? Or are they just kind of withdrawn and just sitting there? Also, think about consolability. Let's be honest, infants and young children cry a lot, but they also console with a parent or a favorite toy or a YouTube video. And so inconsolable is a buzzword in the pediatric population. There are bad things associated with inconsolability all the way from child abuse to SVT. Also, the look of the patient. So are they looking around? Are they tracking you intently, worried about you, following you with their eyes? Or are they looking at their caregiver and engaging? Or are they just sitting there with their lights on, nobody's home type look? Also, speech or cry. Are they talking? Are they crying with a very vigorous cry? Or does it sound weak and kind of muffled and not really that strong anymore? Those are the things you want to take into account for your appearance. Let's talk about work of breathing now. For work of breathing, first, think about any sounds. Am I hearing high-pitched stridor? Am I hearing wheezing? Am I hearing some kind of obstruction? Also, the positioning of the child. Are they tripoding? Are they sitting up if they're able to? Or are they just slumped back and laying down again? Also, look at a general assessment of rate. Is it fast or is it slow? Is it normal for what you would expect for that age, or is it abnormal for that age? Also, are they putting poor respiratory effort in, or are they putting a whole lot of effort in and not really getting much out of it? That's going to be your assessment for work of breathing. Finally, circulation. It's all about our skin for the most part. So we're looking to see, does the child look pale for their ethnicity? Are they mottled? Are they cyanotic? Also, don't forget about any bleeding as well. So this is definitely, again, across the door, across the room exam where we're looking at the skin and seeing, does this child look well perfused or not? So once we've assessed all 3 of those things, we can put them together and determine the physiology going on with this patient. So if they have abnormal work of breathing alone, that's respiratory distress. If you see abnormal work of breathing and poor appearance, that's beginnings of respiratory failure. Also, rarely, abnormal circulation and work of breathing can be together, and that also can add up to respiratory failure as well. For abnormal circulation, that's going to constitute shock. You may see also abnormal appearance and abnormal circulation, and that also appears to be shock as well. If you see all 3 of these things down at the same time, that's cardiopulmonary failure, or basically a peri-arrest situation. That child is dangerously close to coding, and we need to take rapid and deliberate steps to resuscitate that child in a quick time frame. If you just have an abnormal appearance alone and their circulation and their work of breathing is okay, this constitutes more of our metabolic, infectious, and neurologic type things. So this is your hypoglycemia. Maybe it's an occult traumatic brain injury from a shaken baby. Maybe they just had a seizure or are actually seizing at that time. They have electrolyte abnormalities, low sodiums, or they may be infectious. So they have a pneumonia, or they have a meningitis type picture. All those type of things can constitute a CNS or metabolic things from your abnormal appearance type thing. So when to use the crash inpatient protocol? We ask you to at least apply the crash inpatient protocol to every one of your interactions with pediatric patients. However, most of these patients are going to check the goals rapidly and are going to move on from there. But when do you need to use it? If you have a provider impression of extremis or that patient looks really bad, start off with new onset altered mental status, airway issues. We added poor appearance to incorporate the pediatric triangle into this. Also severe respiratory distress or failure, signs or symptoms of shock or poor perfusion, or if you walk in and you generally think the patient is going to code, all these things trip you into the crashing pediatric patient protocol. Once you've recognized those things, do not initiate movement to the ambulance or start transport from the scene. We owe that patient our best attempts at correcting critical hypoxia, bradycardia, or hypotension prior to the movement of that patient. Let's go over some pediatric pitfalls. Here's the top 6 right here that I want to list for you. Scoop and run, med dosing and equipment errors, not using age-appropriate vital signs, errors of omission, not undressing a child, and not including the caregivers in care. We're going to go over those each individually now. So, yes, many pediatric patients are portable. We can easily pick them up, scoop them up, and run to the ambulance with them to try and get them to the hospital quickly. Time and time again, the research is building to say that is a bad thing for pediatric patients, primarily in the pediatric CPR population, but also in our respiratory failure pediatric population and our critically hypotensive ones as well. Scoop and run is detrimental to pediatric outcomes. We actually harm children by scoop and running more than we would by staying on scene and doing a deliberate resuscitation. So please don't grab up that child and run to the ambulance. I know that has been a common practice for us for a very long time across the US, but I ask you to change that practice. Next, dosing and equipment errors. First, stop doing math. We have great tools under our belt at this time to help with this. The Pediatape or Broslo tape contains the ml dosing for each of our medications now. You don't have to calculate how much is my milligrams and how many are my mLs. Use this guide readily for your medication as well as your equipment concerns. So utilize a reference guide also. We've added some things to the protocols, such as intubation or ET tube, sizing, as well as depth. So utilize those things in your protocols as well. Don't just assume or don't just kind of wing it. You have great reference guides at this point. Also, just because we have our ml dosing right there on a page doesn't mean we can't make errors still. So I really ask you, since these doses are unfamiliar for us, to use a medication cross-check when you're giving doses. Check with a partner, run by that dose, make sure it sounds appropriate, and then administer it to the patient. So our length-based resuscitation tape, aka a Broslo, has a hierarchy for the color zone selection. First, if the weight is known for that patient or the parent or caregiver can tell you, utilize that first. That's going to be the most accurate for you. But if the weight is unknown, next we're going to use the tape to measure out the length. Find out the zone where their heels hit, and that's going to be the zone you pick for length. But sometimes we can't lay patients down. They just aren't able to tolerate laying flat. And therefore, we can't use that tape to measure that patient properly. So that comes down to age at that point. So get the age or the estimated age of your pediatric patient, and then select the appropriate zone for you on the tape. So also, the measurement of this has a little bit of nuance. First, the Pediatape or the black arrow at the top goes to the top of the head. For the Broslo, it's red to the head. A common thing that we do wrong is that we measure it to the tip of the toes. Make sure you're measuring to the heel on the tape. You can easily go up a zone by measuring to the toes and end up having a dosing error in that way. So measure the heels on these tapes. Also, verify age-appropriate vital signs. Don't assume that a low blood pressure or a high heart rate or a high respiratory rate is normal for that patient. We see a vast array of patients from infants to teenagers. Each of those has different appropriate vital signs. So again, utilize your protocols to look up the age-appropriate vital signs for your patient and see if that truly is an appropriate heart rate, blood pressure, or respiratory rate for that patient. Let's talk about errors of omission now. What are errors of omission? These are things that we would normally do for our adult patients that somehow we don't do for our pediatric patients due to unfamiliarity or feeling uncomfortable in doing them. These are things like a blood pressure. Maybe we don't get the smallest blood pressure cuff out for our young patients as much as we should. Also, glucose readings. It's critical still to determine is a patient hypoglycemic or hyperglycemic or a DKA. These still occur in pediatric populations. Also, starting an IV. I get it. We don't want to stick kids. We're scared that we're going to miss, but IVs are still important for some pediatric patients. Starting fluids, oftentimes this is just infamiliarity with the dosing compared to adults. And then finally, pain meds have been time and time again shown in the research that we just either underdose pediatric patients or just don't give them at all. This may be due to pediatric patients not being as obvious to be in pain, or they aren't as readily complaining about it as our adult patients. Again, think about all these things and ask yourself, why am I not doing them in my pediatric population? I would definitely do this in my adult and try and bring those same skills that you would do for your adults down into your pediatrics. Another critical error we make is not undressing our patients to fully examine them. As we saw in the pediatric triangle, it's an eyeball assessment. We have to be able to see the chest to assess for abnormal breathing. We also have to see the skin to evaluate for circulation. If we don't undress the patient, we can't see those things. So unzip that onesie, lift up the shirt, start taking a look at your patients. Also, sadly, non-accidental trauma or abuse is very common in the pediatric population. If you don't look at the buttock or the back, you may miss that bruising or those signs of abuse that we would have otherwise missed if we had left the clothes on. And that may be the difference in saving a child's life and getting them to the appropriate care. Also, the research shows that involvement of parents and caregivers in your care is critically important. It's quite frankly the standard of care in pediatric emergency departments now. I get that we just want to do our thing with the patient and have the parents off to the side, but it's important to involve the parents. They want to be involved. That may be something as simply as holding the patient in their arms while you get a blood pressure or get a good SpO2 reading. They may be just holding the patient's hand. They may be showing the YouTube video to keep that patient calm as you start doing that IV. Involve parents and caregivers in your care. It can only help you. Also, even in your worst pediatric calls, such as a pediatric CPR, again, the research supports that parents being involved in that resuscitation and being present is actually therapeutic to them. And so dedicate someone to speak to the parent, guide them through what's going on, reassure that everything is being done. Don't have them in the other room. They want to be involved and see you working hard to try and save their child. Finally, pediatric calls, especially bad pediatric calls, are probably one of the number one things on the list that are stressful after the call. We take these with us. You have to stay well to keep your patients well. So please reach out to your partner, your station, your officers, your supervisor, or some of the campaigns out there such as the Hope Squad or Code Green if you're bothered by these calls. Don't keep it in. We understand these can be very stressful and bother us, and we have to support each other on this. So after this, don't just go on to that next call. Take a minute to decompress and keep yourself well. That completes the Crashing Pediatric Patient intro series.